at the outset, we would like to thank Dr. Sharda Jain ma'am, Dr. Vandana, Dr. Ragini, and all the organizers, Dr. Mala Srivastav, who invited us and are giving us this opportunity to talk about the critical care cases today. So we have got two cases which we will be discussing. One is a case of acute fatty liver of pregnancy, and second is a case of sepsis. So in the interest of time, we will start straight away with the first case. So this is a 22-year-old primi gravida at 35 weeks period of gestation who complained of yellow discoloration of eyes and urine since 3 to 4 days and vomiting since 3 days, and she came to us with labor pains of 4 hours. So on examination, her pulse was 92 per minute, her BP was 130 by 90, and her respiratory rate was 26. SpO2 was normal on room air, 96%. And the remarkable thing, she was in early labor with a PV finding of 3 centimeter, 50% effaced, and the vertex was at -2. So the routine investigations which were sent for her immediately, we found that her hemoglobin was 8.4 and TLC was high, 17,700, and bilirubin was 12.6. AST, ALT were also highly deranged at 544 and 344, and her KFT was also deranged with creatinine of 1.7. Blood sugar was, random blood sugar was 67, and coagulation profile was also deranged. So the viral markers which she had got with us from the referring center were all negative, and the HAV and E as well as the HBsAg and anti-HCV. So the ultrasound was quickly done, and it revealed the single live fetus at 34 weeks, and the LICA was adequate, placenta was upper posterior, and we also found a mild ascites and with a bright liver, and also mild right pleural effusion. So this was the case. So we would like to ask Dr. Alok Sharma that what would be the provisional diagnosis and what would be your concerns when you see such a case?
Ma'am, as it was early declared that the case is AFLP, but besides AFLP, we should also think differentially, that whether it belongs to HELP, maybe HELP could be there, or AFLP could be there, or hepatitis could be there. So after ruling out all these conditions, I think AFLP is the fitting diagnosis here, which is in early labor of pregnancy. And with I think the behavior and the signs and symptoms of the patient is she is going into like MODS also.
Right.
So multiple organ disorder is also there.
Yes.
So this is the diagnosis.
Yes.
Because again the chemistry and the signs, hypoglycemia is there, bilirubin is raised, transaminases are raised, and creatinine is raised. She is having jaundice. So many symptoms of jaundice also are there. So it is AFLP also.
Yeah. Yeah. Thank you, Dr. Alok. So definitely, of all the diagnoses which you have said, she is fitting in into most likely to be a AFLP. And we are worried for this patient because she is already baseline, she has a low hemoglobin, she is in DIC, and she is going into the active stage of labor. So it is a case where all the obstetricians dread the coming PPH. And we would like to share with our audience here that the risk factors for AFLP are basically the fetal long chain 3-hydroxyacyl dehydrogenase deficiency, and prior episode of AFLP is definitely something that there can be a repeat AFLP, multiple gestation, male sex, preeclampsia, HELP syndrome, and low body mass index. Mostly it is a high body mass index which is a risk factor for so many of the conditions, but here it is a low body mass index and nulliparity. These are all the described and published risk factors for AFLP. So to continue with Dr. Alok Sharma, you already told us that there was a differential diagnosis. So how would you differentiate, more
Yes,
from these conditions which you talked about.
Like
Yeah.
if we are talking about HELP, then HELP we are having high blood pressure, but blood pressure is like normal, and platelets are also 130/90, not so much high according to the HELP syndrome. So it is towards the like not so much of high, or we can not put in preeclampsia or mild preeclampsia, you can say. A mild raised BP was there, and platelets are more like in HELP they are more towards lower side, less than 50,000. So and in hepatitis we have got viral markers also are raised. So these are the more features towards AFLP. TLC raised, uric acid is raised, hypoglycemia. Hypoglycemia is again one of the remarkable features. And if we have got one Swansea criteria. I was again explaining that if it is a 15-point criteria, and in these 15 points, if 6 points are in the favor or are showing the features, then we can go for AFLP.
Right. Yeah, so very well said, Dr. Alok. So basically AFLP is related closely to DIC. It is related to a coagulopathy and encephalopathy. So HELP syndrome normally will not have a coagulopathy associated, even though the platelets are low. But whenever the INR is deranged, we should be cautious about a diagnosis of AFLP.
And also,
yes, please, please add on.
Also in many situations, they both can be coexisting also.
Very true.
That HELP
Very
and
true.
HELP,
this
they
thing.
can
And
coexist.
also in
Yes.
the index case, in this case on ultrasound, there was very echogenic
Right.
liver was there, which
Yes.
is a suggestive
Then one thing more also is that it is one of the rarest condition. So
Yeah.
again, you have
But you have to have high
diagnose.
clinical
You have to have an idea.
Yes.
Ki there is
Yeah.
there is one entity called AFLP. Though it is the rarest, but again one entity should be mentioned. Though HELP we come across more
More
frequently.
frequently. Yes.
High
But-
bilirubin and higher transaminases, they are all
Yeah.
suggestive.
They all
And
are
early
suggestive.
onset of coagulopathy.
And
So
again,
all
more
these
of the
define-
features that AFLP is found in the later part of the pregnancy.
Hmm.
So patient is 35 weeker. So again,
Third
so
trimester, specific to third trimester.
to third
Yes.
trimester.
It's a third trimester complication.
postpartum.
Most
But
common.
yes, the entity should be kept in mind that there is an
Right.
entity called AFLP also.
Yeah.
Thank
Most
you.
of the time we'll think only of HELP or hepatitis. So
Yes.
we are thinking on that ways only. So
Just,
if we are thinking that AFLP is something there, then only we are going to diagnose it.
Just one more thing, we are talking about two entities. One is preeclampsia. So one must remember that AFLP, 50% of the cases might have preeclampsia who have not gone till HELP. So there is a point where HELP gets differentiated from.
Yeah.
So that is why we can
there
have a
is
hybrid.
a association, as we said, in the risk factors between preeclampsia, HELP and AFLP. And it is very often considered like a spectrum because there is so much of overlapping between these. So it becomes very crucial to differentiate, even though finally the
Management would be the same.
management is the
Would be
same.
nearly
You
the
have to
same.
deliver in all of them. But here the critical thing becomes for the
Liver failure,
obstetrician
yeah.
how to differentiate from the acute hepatitis.
Right.
Because that is one condition in which we will not be doing the delivery.
Delivery.
So that is why, we had shown this slide in which the differentiation between hepatitis and AFLP
Right.
is very important because they can both
Nearly.
present with acute liver failure, with encephalopathy or with coagulopathy. So this slide is important, I think, for us that
Point taken, ma'am.
yeah.
Hepatitis has
Yes.
to be ruled out.
Okay, so again, this slide is also showing us that in AFLP there will be hyperbilirubinemia, which will be there in almost, every percent, 100%, every case will have it, and transaminitis will be there. It will be there, raised WBC also in almost all the cases, and the coagulopathy as well as increase in the creatinine. So, as Dr. Alok said, high index of suspicion is very important, and we always perform the first line tests in such cases, which were done in our case also. And this one very interesting study had said that if you use GIT symptoms and aminotransferases and bilirubin, bile acid and APTT, PT, you can with sensitivity of 97% diagnose AFLP. But if you add sugar and blood pressure and WBC, it decreases accuracy. So this is one study which we just thought we could mention here. So Dr. Niharika, what are the complications which you are worried about when you are dealing with such a case?
Yeah. So complications, per se, we need to know the complication. It will help us in the management, and per se it will also prognosticate the patient. So complication commonly, as per in this patient, there is the patient's, she's in labor, her sugars are on borderline 65. So blood sugar monitoring should be done vigorously in these patients until they have their normal nutrition restored. So that has to be done, because they can become comatose in case of hypoglycemia, which can be further confused with hepatic encephalopathy. So dextrostarting should be done regularly in these patients. Then they have a tendency to bleed per se because of the coagulopathy, and they are predisposed to PPH. So this becomes a vicious cycle which can also further lead to DIC and a hemorrhagic shock in these patients. And this patient already had deranged kidney functions and as well liver functions. So kidney functions, in these, the most common cause is the ATN that is caused in these patients, which is further aggravated by the hemorrhagic shock. And these are also, predisposed to nephrogenic diabetes insipidus in the coming future. And for the liver, basically they can undergo hepatic encephalopathy. It is very important to monitor them for their conscious status also, because we should diagnose hepatoencephalopathy in the stage 1 or 2. She should not go into 3 or a comatose stage. And they can have GI bleeds per se, and for that the prophylaxis should be given in these patients. Then apart from these organs that are affected, they can go into encephalopathy, and then they can have multi-system organ dysfunction syndrome can be there, and which can further lead to sepsis. So per se, there are 3 important prognostic factors. Any patient who is deeply comatose, then there is, if the prothrombin is less than 40% of the normal value, and if there is any extra hepatic involvement, the prognosis is very poor. Though we say that termination is the treatment for these patients, even after that, they might not come into the reversible phase.
Yeah, thank you, Dr. Niharika. That was very well said. So again, Dr. Niharika, this question is for you. How would we manage her delivery, and any special precautions to be taken?
Yes. So for this patient per se, I would, it is, the only good thing in this patient is that she's gone into labor. There is no time that we have, wasted in making the diagnosis. So sometimes we say patient decides on her own, let her decide. So that's one good thing. So sugar monitoring has to be done. I would like to augment this labor. And anticipating there should not be any delay, the dictum that we follow in hepatic in the patients of AFLP is that they should deliver within 24 hours of when the diagnosis has been made. So, and an anticipation of PPH should be made in these patients, and I think second stage of labor should be cut short without any trauma during the delivery.
Right. And we avoid the episiotomy.
Yes.
And if a cesarean is done, then I think putting a drain is a good idea in such cases.
And I would get a floor PAC done beforehand when she goes into labor.
Yes. And this is one of the guidelines with the FOXI and the Indian National Association of the liver study of the liver. So they took out their guidelines about management of jaundice in pregnancy, and they said that for AFLP, cesarean section may be preferred over vaginal delivery. Especially as you said, if the patient is not nearing, imminent delivery is not there. So even though it was a weak recommendation, and I don't think all of us follow that we immediately take for cesarean. I mean, I would like Dr. Deepika Deka, madam, who is our expert, to say something. What is her opinion about it?
So basically, if there is, I think you had a slide which showed that the coagulation profile was deranged.
Yes.
So that is one indication basically. If the coagulation profile is deranged, then the prognosis will become very bad. So in that case, both the things have to go simultaneously. You have to give her the blood components, build her up, and deliver as soon as possible. So the sooner is by cesarean section, but they have to go simultaneously.
Yeah, thank you, madam. So here in this
Just
patient,
to add, like we are cesarean section, though it is necessary only if the delivery is delayed.
Yeah, right.
But if the delivery is imminent and we are avoiding episiotomy to prevent any
hematomas.
incision.
Yeah.
So cesarean is, I think, not a good idea.
No, definitely. We also don't think that we would rush for
The
a cesarean.
idea is to deliver.
Yeah, we would like to
So if
deliver.
she's already in labor, like this case.
Yes.
then
And-
it's good for her.
And if the bishop is favorable and we feel she will be able to go into labor fast, so I think we would all like to do a vaginal delivery.
Ma'am, just one thing I wanted to add, which I just skipped, which is very important in this, era of medico-legal litigation and everything. A thorough counseling has to be done because these patients might have fetal distress. So you need to be very thorough with your counseling consents that with coagulopathy we will not do a cesarean.
It is not only fetal distress, even mother, we can lose,
Yes,
maternal mortality could be there.
maternal, we are-
Because
Mother is the
patient will be
Mother
quite
is the
morbid.
bigger, yeah.
So we have to do not only fetus, but maternal counseling should be
Yes.
Yeah.
there side by side.
Counseling
Mother-
is
It's a
very
proper-
important. There
And
is a
negative counseling should be
high
there proper.
mortality for both
High
mother and the
mortality for
fetus.
mother, yeah.
So
Yeah, the relatives have to be, you have to be told
Kept
about.
in, yeah.
So these are the cases which may later on land up in medical legal problems. So it's very, very important that you have communication with the relatives, with the husband. Tell them about the seriousness of the condition. Write it down on the case sheet. Tell them, get them signed. Before you take up a patient like this for management, during a cesarean, you have to get a high-risk consent on the case sheet by the husband or the family.
yes,
Here comes the sometimes negative counseling also helps. So negative counseling should be there for, in this case, I think positive counseling is there, but negative counseling should be there, that we can have loss of both the things, fetus and mother both.
See, with INR, like in this case, INR was 2.7, 2.4 or 2.7.
Yes, 2.7, yeah.
So one always have to be aware what is the coagulation status when taking up for cesarean
Yes,
section. Give
yes.
components, and if the delivery is
Right.
delayed, then take up for the cesarean
Right.
section.
So the labor progressed spontaneously and she delivered a term live male child of 2.5 kg by normal vaginal delivery with the episiotomy had to be given because of tight perineum, and the active management of third stage was done, but patient had atonic PPH with blood loss around 800 cc. So Dr. Rashmi, would you like to use the balloon tamponade for this patient? How would it help?
Yeah. So in such a case, like I think that primary management has been done, like oxytocin,
Yes, that all has been given already.
Massage has been done. So we like to go for, because she had an episode of atonic PPH. So it's better to go for the balloon tamponade, as it increases the intrauterine pressure. It presses on the endometrial surface and capillary bleed, venous bleed, and if the pressure is more than the arterial bleed, so it stops. So if the Bakri balloon is there, we always use the
Yes,
Bakri
that
balloon,
is
but
the
sometimes
preferable.
it is
Otherwise
preferable. And also
Right.
when the patient is in labor, give aggressively component therapy should be given, and one has to be prepared for this emergency and keep the balloon ready. So if that is not there, then our indigenous like condom catheter, or even the Chhattisgarh, if large bore Foley's is available, Chhattisgarh,
Yes.
catheter is also a very good thing. So balloon catheter we go for, though it is written that DIC is a contraindication,
Yes,
but what
but
I
still
did
we
not
do
find
it.
out is that I think it is a contraindication because it may not help. So chances of failure are more. But per se, we generally use because
we
it
use.
is a desperate situation, so we use it and it really helps. So side by side, we will improve the coagulation status. So in all probability, within 24 hours, patient will come out of
Yes,
it.
in fact here many times we use it prophylactically without a
Right, yes,
PPH
ma'am.
also.
Yeah, and
so
there are
that is
reports
the
also.
what I think everybody
Yeah.
is nodding their head vigorously. I think it is a general practice amongst all
Yeah,
of
yeah.
us to use it
Because
quite,
somehow in such cases,
liberally.
atonicity happens.
Yes,
because
it
whatever the
happens
tissue
because
effect
of
is
the
there.
hypovolemia
Yeah,
and the
so-
generally
so the-
yeah.
Yeah.
Ma'am, I would like to add, like, I don't know how many of you practice, but somewhere I have read and I put on 5 Foleys simultaneously with 40 cc of fluid, normal saline in each Foleys in the uterus. And the next day I keep one by one out. This also saves the...
We use the condom catheter.
I used,
Because that
and I have saved 6 to 7 patients atonicity with this method only.
Yes.
I put 5 Foleys simultaneously with 40 cc and I remove one by one with...
So why not to use
Just I am
condom?
losing, just the Foleys I have wasted, 4 Foleys I have wasted.
But use the condom, no?
It is just because of we are having a desperate situation and putting that, we'll save much and the blood loss is very much less.
But condom catheter, the
To
condom.
prepare condom catheter when you are alone in the labor room, just with the help of staff nurses, it is very difficult for you. And in my situation, sitting in a rural background, it becomes difficult for me.
Yeah.
So
What
I
about the
did,
suction
this is
cannula?
my
You
practice,
could
I
save the
did.
patient.
What about the
I saved the
suction
patient.
cannula?
Okay, so that's a point well taken. I think we move ahead. We are having the time constraint.
I just want
Yes.
to comment as a expert comment for each of the steps, you know. So I want everyone to realize that PPH, because of atonicity, in this case is not the common cause of PPH. The commonest reason would actually be the DIC.
DIC.
So that is something, and I remember in AIMS, you know, the experience when I was an assistant professor was that the ICMR chief, you know, at that time, Dr. Satyavati, she lost her only daughter on this time. So
Yes.
it's very, very dangerous
Very
situation.
Yes.
So you have to be, we did our best, you know, I mean, of course I was just an assistant
So
professor.
that is why when
But this can happen, and the patient will die more because of coagulopathy rather than atonic PPH.
It becomes at times a combination because it becomes like a vicious cycle. The more she'll bleed, the more hypoxic she becomes, and the oxytocin receptors, the oxytocin will not act on the receptors, so it becomes atonic. So it begins with coagulopathy, ends with a very, multiple factors.
So that is why, just a word, that is why we have to monitor the fundal height also.
Right.
So sometimes the
Yes,
drainage is
that
not
they
there.
are when they are. So we always
She
the
may
fund.
keep on bleeding inside because
Right.
of DIC.
Yes.
Yeah.
Yes, so we are continuing with that. In that, just now we will discuss that also. So uterine tone was reassessed. It got well contracted, but still there was a trickle, and that element of coagulopathy is definitely there. So Dr. Sarveshwari, for the management of DIC.
So she's not there, I'll take it,
She's
yeah.
not there. So
I take it. So-
Dr. Vandana, very briefly, please.
Yeah.
because one more
The
case is there.
briefest thing is that we are looking at DIC as another cause. As we said, it is a simultaneous occurrence. So we have to see that component blood therapy, keeping the patient warm, keeping the patient well oxygenated, good antibiotics, good fluids, and her patency of the airways. So it is just a shock management which has to be given, and blood component therapy is the base to correct the DIC.
Yes. So hypothermia, acidosis, and oxygenation. You know, so you have to correct the hypothermia and acidosis and give good oxygenation to the patient. So these three things are very critical. Component therapy, you have already told us, and this is the.
Can I just,
yeah.
you know, as an expert, I think I have the right.
Yes, madam, please. You have all
Shift
the
her
right.
to ICU.
Yes.
She is now to be shifted from labor room to ICU. Okay?
Rest, yes, actually.
Right. And then with this, this table is showing you the triggers at which we have to give the FFP. And of course, we have got, you know, cryoprecipitate is something which can be very useful if you want to decrease the volume of transfusion, because with the FFP, you do give a large load of volume, and with already a patient in renal injury, AKI, it becomes more challenging. And we also have the fibrinogen concentrate these days. So it can be very helpful in patients who are in DIC. So this is about the fibrinogen concentrate, which we have also had the, pleasure of using once, and we could save that patient. Yes. It is very expensive, but
we had the sample.
yeah, we had. And about the recombinant factor 7A is also coming up with its role in PPH nowadays, but this is for severe PPH, and there is always a risk of thrombosis, so very limited role. But the marketing of this product for PPH is also, at the moment it is picking up the speed. So, Dr. Vandana, the management of AFLP.
That's what we've already
We
discussed.
have
that
already
has to be.
discussed,
Yes.
And Dr. Niharika already told, that correct the
Yes.
coagulopathy,
Correct.
fluid and electrolyte balance is very critical. Dr. Deepika Deka said that shift her to ICU. So this is what in the ICU, she needs to be very strictly monitored for her fluid and electrolyte balance. Her hypoglycemia has to be managed because she is likely to go. So normally we start a dextrose 10% drip at a low rate, that's what we do in our own ICU. We give continuous dextrose drip to the patient so that she doesn't have recurrent episodes of hypoglycemia. And of course, if the patient is having a MELD score, the liver failure score of more than 30, then early transfer to the liver transplant center, it is very crucial to save the life. Then for the investigations in the newborn, because
So,
this
yeah.
patient
Yeah, it is because of the condition itself arises because the fetus is deficient of that
Yes,
enzyme.
yes.
And so the fetus has to be screened
Yes,
for it.
very
so the
true.
fetus is also at risk.
So genetic
for-
testing for the
Yeah.
fetus, for the parents, it is because if it is a recurrent phenomena, we said, so it is very good if we could do the gene studies for them. And the baby has to be monitored for hypoglycemia. That is one risk the baby has. So of course, in the future pregnancies, again,
It can
in
be
10 to
repeated.
15% of the cases, the patient can again have the same problem. And now this one last slide for this case, it is that there has been an upcoming role of studying the antithrombin 3 level in the third trimester. So if you know it is, they are saying it can help in predicting whether this patient can go into AFLP or not. So we don't really know how useful it is, but some studies have shown that this is effective. And of course, if there is a history of previous AFLP, we should be monitoring their coagulation profile in every visit in the third trimester. That goes without saying, and LFT also, because early detection, you can do the delivery in time so that the patient doesn't have a full-blown picture. So I now hand over to Dr. Rekha to conduct the second case.
So we go on to the next case, and this patient was a multi-paras patient. She had a full-term vaginal delivery at home 3 days back and came with pain, abdominal distension and signs of obstruction. And she had fever for 4 days and foul-smelling lochia. And the positive history was there was history of premature rupture of membranes 2 days before her delivery. Previous deliveries were, one delivery she had was uncomplicated, and medical and surgical history in the past was not significant. The patient's GCS at admission was 12. She had mild pallor, there was no icterus. Her temperature was 39 degrees, pulse was 132, respiratory rate of 36 per minute, and her MAP was 56 millimeter of mercury, and SpO2 was 93% on room air. And her chest was clear, and she had tachycardia, no other thing we could identify on examination. Per abdomen was distended, and there was tenderness and guarding. Bowel sounds were absent. Uterus was subinvoluted, 24 weeks size with tenderness, and there was foul smelling lochia on PV and PVR examination. Os was open, but we could not feel any POCs there. So with this thing, I would like to ask Dr. Alok, what diagnosis would you like to keep here for this patient?
Like with these findings, I will go with sepsis. Sepsis is the first and foremost diagnosis, and she is going again into organ failure. If we are taking the SOFA square, the score, and septic shock could be, she is in septic shock.
Yeah, so thing is here that one thing is that she is in shock. So we'll just come on to the definitions first, that what is sepsis and how do we say she is in sepsis, and if we say she is in septic shock, what should have been fulfilled before we say that she is in septic shock. So as you rightly said that she is going into organ dysfunction, although we do not have all the organ tests complete, SOFA score is not there with us, but still we can see that her MAP is less than 70, so that gives her a score of 1, and her GCA score is 10 to 12, so combining 3, so more than 2, she is
Yes,
in
organ
failure. So
failure.
clinically she has sepsis infection, and she is in organ dysfunction, so we can say she has sepsis. Now next, coming to the definition of septic shock. So here, if we are not having serum lactate levels, then we'll at least have to give her fluids, and if we are not able to resuscitate her with her fluids, and we have to give vasopressors to maintain her MAP, then we'll call septic shock. Although we say that she is in septic shock, why we have to be very clear in calling them septic shock or just shock with sepsis is that the moment we label them as septic shock, the mortality means is more than 40.
High.
So next thing, Dr. Rashmi, because we are, sepsis we have done many times. I think audience have also heard it so many times. So what we are going to do now is sticking to what is new. We have had 2021 sepsis guidelines. So just to know what is new in this sepsis guidelines which has come up recently. What is new in sepsis screening here?
Yeah, so for the diagnosis or this making a provisional diagnosis of sepsis, we used to use the, like you have talked about the SOFA score, because we have to know that organ dysfunction is there along with the infection, then only we say sepsis. Sepsis does not mean plainly infection. Okay, so the SOFA score, it needs so many lab results, so we have to wait. And we know that in sepsis, you can save the life only if you act fast. We talk of 1 hour, we talk of 3 hours. So, so that is why quick SOFA came. Actually, in 2016, it was recommended that quick SOFA can be done, which is a quick bedside examination. You just see 3 things. That is the blood pressure, you see the respiratory rate, and you see for the mental status. So if 2 or more score is there, then you label it as sepsis. But after that, after 2016, in many studies, it has been seen that quick SOFA is not a very sensitive as a single, if it is used as a single marker for the diagnosis of sepsis. So it will not pick up all the cases. So roughly around 25-26% cases are picked up, though this is a very good marker for the prognostication or the outcome. Yes. So that is what came up in 2021, that quick SOFA as a isolated screening tool should not be
so
used.
Very true. Like though we have not stopped doing quick SOFA because it does give us some information, but then there are other scores that are there. So Muse was there, which was very commonly used, and but the only thing was this was challenged because it was not based on any, like it was just based on the prediction model. Then came the Carley score, and with this score, if you see the score, it is not very difficult score. You can do the scoring even when the patient has just come to you. Yes,
and the score is basically they use the statistical model and methods.
Yes.
So more of a predictor score. But there are so many scores are there.
So
even now there is not a single definitive score. Is I think
there is no single definitive score. Very right. That especially in obstetrics, we have not come out with any score which has been done on antenatal patient itself. But there was this, with Carley's Muse score at our center also under the supervision of Dr. Jyotsna. So we had seen that So though they say that score of 4 to 5, aggregate score of 4 to 5, it makes it slightly at intermediate risk. But we also found that 4.5 score, if you have at cutoff of 4.5, many patients they were having this having poor prognosis, means they were landing up in high dependency unit. But this study actually was not only in sepsis patients. This was in general patients who were the patients who were coming in the hospital. They were all screened, and all those who had we just did Carley score in that, and we thought that the chances of their landing in ICU were higher if this Carley Muse score was 4.5, more than 4.5.
Like to say that actually all these scores, they have a relevance because they are generally done in ICU patients who are already sick, but the main advantage of these scores is if they are done in the wards.
Yes.
So because retrospectively, whenever the mortality occurs or you review the cases of near miss mortality also, that many times some criteria which has been seen by a junior but it has been missed. So if you have color coded charts, so one knows what is to be done. So these
so with Carley's Muse, I think it is very simple score. You can do it in the wards, and when the patients are in ICU, we have SOFA because there we have all the investigations, so we can even keep doing SOFA score daily and see how the patient is, doing in the ICUs. And so next, coming to the 1 hour bundle for the management of septic shock. So Dr. Vandana, because this is very, very important.
Very important,
so we all have to be
the moment the patient walks in and we've realized that she's in a septic shock, she needs urgent treatment. That is within 1 hour, we have to start everything going on simultaneously. The first thing, because she is in sepsis, antibiotic has to be given, but blood has to be taken for culture and sensitivity. Her airways have to be seen that they are cleared, or if she requires oxygen on a high rate. Then her blood pressure has to be seen, her hypotension has to be covered, hypothermia has to be covered, hypoglycemia has to be covered. All the parameters, they have to be covered simultaneously without wasting time. That is 1 hour bundle, basically.
So very important thing here is that 30 ml in 3 hours. So it is called 3/30 rule. So that has to be followed. But important thing what has come in 2021 guideline is that you do not complete the fluid resuscitation before you go on to the vasopressors.
Yes,
Within
yes.
1 hour only,
go
if the
everything.
patient is not responding, you go with the vasopressors.
Vasopressors also.
So ma'am, your comments like till now, if you...
Yeah, I think what has been said that you should take the blood samples first. You know, because it's
That's
very
what I said,
important.
ma'am. Blood samples have to
especially
be.
you said that the patient is very anemic also. So what happens is I've seen that the patient gets blood transfusion and everything, after that she's shifted. And then you're taking the sample. So that is not correct. The blood culture should be taken before you start the blood transfusion. Yeah. And the antibiotics, definitely. And then what antibiotic to start? So you must always, you're going to discuss that?
Yes, we
okay,
just
then I won't talk
briefly
about it.
But
yes. So you must very well know which antibiotic to start first. And before you are waiting for the urine cultures, before you're waiting for the blood culture report, so that antibiotics are started immediately.
A broad spectrum,
yes.
yeah. And then according to the culture, it is tailored later on.
Yes. So you should take the samples and everything before you start any treatment.
Yeah, yeah. Everything has to go simultaneously. That is the 1 hour bundle.
Yes.
So the
So
moment you're putting in the line, IV line, the samples are taking simultaneously.
So
at the
one
same time.
important thing here is, as ma'am also said, like do it promptly. You should have the facilities with you. But in case you are at a place where you do not have facility, but your patient is in septic shock, if within 1 hour you cannot collect cultures, then give antibiotics. So that is also very important thing, which is there in this sepsis guideline. Although we should all, you know, the places where we are working, we should have this facility. If you have facility for giving IV antibiotic, we should have facility for taking cultures. So and half an hour delay is there, it's okay, but don't delay it for more than 1 hour. That is also important. And then investigations, like as expected, her liver function was deranged, KFT were going on higher sides, coagulation was deranged, but her infection like was not, you know, she had mild free fluid in the abdominal cavity, and uterus was postpartum, though it showed signs of endometritis also, and ABG had shown lactate level of 5.2. So here it fits into our diagnosis of septic shock. Yes, ma'am. Ma'am wants to make a comment.
At this point, I want to say that an ultrasound will be also very useful, because, you know, why should a healthy woman like this just go into septic shock? She might be having some retained products of conception.
Yes.
So whether the placenta has been delivered completely, that if she's delivered where in a hospital, otherwise if she's delivered at home, she delivered at home.
Yeah,
na?
she delivered at
so,
home,
So
but-
you have to rule out an RPOC.
So many a times, even with hospital deliveries also, we see that patients, they
RBOCs
do
are there.
come with some adherent placenta,
Right.
though it is generally mentioned in the notes that there was difficulty in removing the placenta, but then very ma'am just emphasize, and we all know that, you know, your laboratory investigations have to be there, because then early surgical intervention role comes here. So it may be that you have to do laparotomy to drain the pyoperitoneum, or maybe otherwise you have to remove these POCs. So Dr. Vandana, like, patient was catheterized. We're coming to the management of the patient. So how will you manage this patient?
So as I said, that is the 1 hour bundle way. We start by starting in IV line, taking all the blood cultures, all the blood samples for laboratory investigations. Then fluid have to be given, broad spectrum antibiotic has to be given. She has to be, her airway has to be taken care of, oxygen at adequate rate has to be given, and we have to see that we are not overdoing with the fluids so that she goes into pulmonary edema, and we are not stinging on the fluids so that she goes into acute kidney injury. So basically all the parameters, and we are focusing on multi-organ disease. So we have to see that all these critical organs are taken care of.
Yes.
Urine input, output charting, everything. Yeah.
So it
everything
is
has to
very
be-
important. Why it is important is we are giving fluid. So initial resuscitation we have to do, but after that you have to look for
Yes,
the output.
you have to
and you have to
monitor.
accordingly.
Monitor.
Yes, and her, like, you have to keep a watch for her KFT and LFT also, because the antibiotic and other medication which you are giving, you may have to adjust it. But just because we had very short time here, so I have always been included many times my antibiotic policy. This time I didn't include that because of the shortage of time. So if Niharika, you want to talk about antibiotic, just briefly say about it. The important points, you know, which we always focus on when we are giving antibiotics?
So very important for these patients who come into shock, they are not catheterized, we catheterize them and we see there's no output. Do not hesitate to give a full dose of the antibiotics. The first shot will not harm her kidneys. Mostly we give a broad spectrum which covers gram negative, gram positive as well as the anaerobic. So what we are preferring is tazobactam plus clindamycin or a metronidazole can be added, and as we go higher up, if they do not respond, mostly the cultures report will take time, and sometimes the results are futile. You don't get the cultures positive, so then you shift on to the meropenem or imipenem groups can be shifted.
Yes, so that can be done, and if you suspect MRSA, then one cover for MRSA has to be added. That is very important here. So, and full dose, as she said, because anyway you are going to give volumes, and it is not a volume depleted shock, it is a hypervolumic shock, so you have lot of fluid volume there, so don't hesitate in giving first dose as a full dose here. And which fluid, now because there has been change in the guideline here, Niharika, so that is why we have included this slide, that which fluid will you prefer?
So previously, I would say during our times when we were postgraduate, we used to give a normal saline, de do, Hestar de do, ye de do. But now these days the recommendations are very clear. We give crystalloids which are isotonic, and the best is the Ringer's lactate. It does not exert any oncotic or osmotic change in the blood plasma volume, and this has to be done during the first 3 hours. We have to give this fluid resuscitation as 30 ml per kg of body weight, and it is very important to stick to the guidelines, because in case you do not give it within the first 3 hours, there's increased chances of ICU stay in these patients, and moreover the chances of mechanical ventilation and a refractory hypotension has been seen in these cases.
So this has been observed that even patients who were very high risk, there was increased risk of mortality if you restricted the fluid. So initial resuscitation is very important. I think this fluid responsiveness we have done many times, and because of the shortage. But one thing I would just like to say, capillary refill test has been highlighted in 2021 guidelines, and it's a very simple test, so we should be doing it. And this passive leg raising, it is a very simple bedside test which can tell you if the patient has some cardiac problem and you are hesitating in giving fluid, you can check the responsiveness by this. And another important thing which is important here is the Dr. Rashmi,
we are unable to do this leg raising test.
Yeah.
So we give fluid. We give a bolus of fluid, 250 or 500 ml, and then see the response.
Yeah.
So one very practical point, as Rekha ma'am also highlighted, such patients are usually kept in our HDU or ICU. So please insist on getting a portable probe, and whenever you will be, first your mind will be on the uterus to see the retained products or any collection. Please put in the probe on the IVC also. If you're not, well versed, ask somebody to do and see the IVC. And it's an easy thing that can be done. We do it day in, day out. So get into a habit of seeing the upper abdomen also.
Yeah, sure. And this is very important. One more thing which is new in this guideline. So just a word about, anyone wants to take, you, Dr. Vandana, you can.
For the IVC collapsibility?
No, we have not talking about this.
Hydrocortisone, yeah, it is very important. And hydrocortisone, as we have been using since our residency times, this drug has really proven its merit, and we have to give in full dose 200 milligrams in 24 hours. That is 50 milligrams has to be given every 6 hours.
So after 4 hours of starting vasopressor, if BP is not
rising,
then
we have
hydrocortisone. It is there in 2021 guidelines.
Right.
So you have given her antibiotic, everything.
Right.
Do not hesitate in giving it. It does improve the outcome. So Dr. Rashmi, can you just talk about these additional therapies which are important?
So these additional, and a word about the soda bicarb, I think we missed that, right?
Please talk
so
about that
if
also.
Lactate is high, and she's in acidosis, then you have to give the soda bicarb.
No, if not, if lactate is high, you give it if the patient is going into acidosis and pH is less than 7.2.
Like in this case, it was less. Right?
Till 2016 guidelines, they were saying till 7.15, don't give bicarb, but now they say after 7.2.
Right. So if it is less than 7.2
yes,
and
you
lactate
give it,
is
and
high,
those
then
patients who have renal involvement, because there also
Yeah,
bicarb
then
will be low,
also.
so
Then
there
also
also
you
you
have
have
to
to
give.
give the
Right,
this
right,
thing.
right.
And in addition to that, the insulin.
So insulin, you have to, target value of glucose should be 140 to 180. So you have to see that if they are into hyperglycemia, you have to give insulin therapy has to be given. Then temperature has to be brought down, and the thromboprophylaxis, they are prone for the thrombosis also. So thromboprophylaxis has to be given, and also the proton inhibitors, because they are there is a controversy though
All
about that,
patients
but
in
they,
high
as of now, they
dependency
say
unit
that
should be on prophylaxis for stress ulcers
stress
and
ulcers.
thromboprophylaxis.
Yeah.
Be it mechanical or pharmacological, that you can decide. And there is a
Okay.
role of early renal replacement therapy. Immunoglobulin role is plus minus,
Yeah.
and antifungal if patient is neutropenic, and
Yeah.
early surgical intervention, as Dr. Deka very well said,
Yeah.
that just do
So
not
the
miss a septic focus.
Yeah,
So
focus
do-
is there, then after antibiotic
Yes.
cover, therapeutic dose has been achieved, means
Yeah.
in the blood.
Hanji.
And like in this case, there was a features of peritonitis, tenderness, guarding all over abdomen
Yes.
was there. If
So
she
it
does
was
not respond, she may
spreading.
next day, later on also go into pyoperitoneum, then we
So
have
you
to
have
drain
to
that.
follow maybe
So we
with
have
the
seen
ultrasound
many
if she
patients,
doesn't improve, you
like
do.
earlier, like we used to say, if upper abdomen there is tenderness, guarding, be more alert, and then
That's
lower abdomen is okay because uterus is there.
Yeah, so final
So-
comment from
Yeah,
our
the expert, I'm
Yes.
waiting for that. So I saw that you have written insulin. You know, before that, I think it's very important that you do the electrolytes. Electrolyte imbalance is very, very important in cases of septic shock. So because what insulin does is that it brings the potassium back into the thing. The other thing is she had paralytic ileus, if I am
Yes,
not mistaken.
she had
So we need to
paralytic
take that also under control. She needs an NG tube. NG tube should be given and bowel rest should be done. And we have to, they're very, very, yes, NPO too. And input-output chart has to be maintained, and that's all we have to do.
Yes, so we talk about early nutrition therapy, but you have to look for the patient's bowel motility. And first 48 hours anyway, we have to give rest to the bowel, and then if patients can accept, we should start the early enteral therapy. Yeah. Thank you so much, and thank you organizers for giving me this opportunity with Dr. Jyotsna. Thank you so much.